Yes, hello and welcome to the Tulip Airway channel. This is video number 6 entitled The Tulip Airway Can Do What Nothing Else Can Do. In this video we will be going over the various unique abilities of the tulip. This particular video will go through a quick recap just to remind people or new viewers of where the location of the tulip is, what the neurological stimulation is and why the tulip is unique in how it functions. Then we're going to talk about then we're going to start talking about the unique abilities. We'll start with semi-conscious tolerance, all right? We'll talk about self-extubation, then we'll talk about upper GI endoscopy and orogastric tubes as a combined, because it's roughly the same thing. We'll divide bronchoscopy and endotracheal intubation because there's different aspects to that. And then we'll talk about how tulip can be of use in ENT, dental, nasal surgery so that you don't have to intubate your patient. Now, with a quick recap, that's a tulip airway. As you can see, 5 sizes. The clear one on the top right is specifically for tubes, bronchoscopes, upper GI endoscopes and ET tubes. You can intubate through them all, up to about a size 7 cuff tube. Versions with the headband, versions without. Right, now the tulip is completely different. The video 1 specifically goes through this. It's located in the oropharynx only. It's not supraglottic. It doesn't sit right down here like a laryngeal mask does. It sits up at this level. Just so you can see, here's one of the pediatric versions, but basically it sits at this level behind the tongue, whereas something like a laryngeal mask sits right down here with the tip in the esophagus surrounding the laryngeal inlet. Now that's my thyroid cartilage there. So this thing would sit behind it like that. So that's why you cough, gag and vomit with something like an ET tube. The tulip works on a different function, a different methodology, circumferential oropharyngeal seal. Now it basically fills the whole entirety of the oropharynx from soft palate, tip of epiglottis, only in this region controls the tongue fully. Now that's the whole oropharynx. It seals in a circumferential manner, which is why it's new and unique. It actually seals round the whole tube. Now, that then therefore means that it sits only in the oropharynx, which therefore means that it only stimulates the glossopharyngeal nerve. Now, this is important in everything I'm about to say. Now, we are going to talk about the oropharynx as a unique place, because basically it's the common denominator in the human anatomy, isn't it? Everything goes through that. Everything goes through here, right? So that means we can do upper GI endoscopy, we can do bronchoscopy, we can intubate, and we can come up with new stuff for ENT, dental and nasal surgery, because it's all through the oropharynx and therefore all involving the tulip. Now, let's talk about semi-conscious tolerance. Very useful for induction and recovery, very useful for out-of-hospital use, very useful all round. And self-extubation is roughly the same thing, so I'm going to group those two together. Now notice what I'm saying here is they are awake. Glasgow Coma score 14 with cough reflex return. I'll show you a video. Here we go. Now this, I think it needs to be understood that semi-conscious IPPV control you can't do with an LMA, you can't do with an iGel. They're just too big. They gag, they vomit. It's just not possible for an LMA or an iGel to replace a Guedel. I think people know that. Okay, here is this lovely lady who's consented to the use of a video during the clinical trial. This lady will basically wake up, she'll pull the tube up herself, she will then cough at 8 seconds, she'll go, she'll then answer questions. She has slight slurred speech, so I say GCS is 14, but she's answering questions. I think that's pretty clear.
You pull that out if you want to, Anne. That's good.
Good. Excellent.
How do you feel? You wide awake?
Yes.
How's your throat feel?
Okay.
Thank you very much.
No, I think it's fair to say you heard that cough. So, I mean, honestly, imagine that in airway burns, post-ENT surgery, post-tonsillectomy. In every situation, you can probably reduce staffing in recovery because there's no longer any mask holding required. So it's not one-on-one. You can leave them in with the tulip. I recommend you don't disturb them. That way, when they wake up and pull the tube out, they really are awake. You didn't stimulate them. Now, this semi-conscious use is very useful, and that's probably why the Guedel is the most widely used airway device in the world, because of this semi-conscious stuff. But we're talking about induction and recovery for starved elective anesthesia, right? So you could do 80% of starved elective anesthesia on a tulip, right, the basic stuff. And every time you intubate or extubate, you know, with an ET tube, you need a tulip for induction and recovery. So you could actually put the tulip in first, intubate through it, just leave the whole thing in, and then when you extubate, facilitate extubation. The patient will do that themselves. Now that would be particularly useful post ENT if you've got, like, you know, clot, bleeding airway, or that. If you've got a cough, you won't aspirate. Now, particularly, you know, this semi-conscious use, all first-line airway intervention. So we're talking about accident emergency ER, the wards, hospitals, resuscitation, out of hospital use, particularly paramedics. You're particularly on my mind. If there is basically 2 paramedics per ambulance, as is the case in the United Kingdom, if one is stuck doing Guedel mask ventilation and the other's doing chest compression, who's driving? So basically it's a case of you put a tulip in, you inflate, you put the headband on, because we made you one, and you attach to the ventilator. One guy keeps doing the chest compressions and the other guy starts driving. It's a big deal. It's particularly useful for children at home, as in children using it on their parents at home. So let's start with upper GI endoscopy and orogastric tubes now. Now, current upper GI endoscopy method, right, it's all very unstable, okay? There are bite blocks, endoscopy masks, and nasal positive pressure delivery devices. So none of this is optimal. Okay, but listen, be careful here, because when I was going through this, AI told me that a laryngeal mask airway can be used for endoscopy procedures. No, it can't. And that's basically quite clear, I think, because basically if this is right up against the laryngeal inlet and you put an endoscope through there, how's it going to get into the esophagus? Okay, so be careful. AI is wrong. Okay, can be wrong, is wrong. Here's an example. Now, for upper GI endoscopy, what do? You can intubate, because there's that reflux thing going on. You can jet ventilate, or you could use this new management technique called Thrive. I don't know that much about, but the point is this clearly is an insecure airway. You're not in control. The outcomes are poor. All right, you can die. Now, sure, that can happen at other times, but basically the reason this is a problem is because you're getting intermittent ventilation and intermittent oxygenation. You're running hypoxic, you're running hypercarbic. The patient is probably more irritable than they would be because you're in and out the airway the whole time. Probably requires extra sedation because of it. Right? Probably wouldn't need that level of anesthetics or sedation if it had a tulip in. Right? Now, so upper GI endoscopy and orogastric tubes take the same route. Right? Both through the tulip breathing tube. So let's go through the tulip method, okay, of upper GI endoscopy, which is put a tulip in, put a bronchoscope through the tube. Okay, so you start off with a connector like that, right? In England they're called catheter mounts. I don't know why, but they are, because it's not mounted to a catheter, but it is a mount. Now these things are quite important, particularly the swivelly types, because a tulip is so small that you have to be careful that hanging the anesthetic circuit off the tulip doesn't pull it out of the mouth. So you need one of these. But if you notice what's special about this is one which has a clickable top. This comes off, and then there is a hole straight through it. Now, there you go. The top comes off, and there is now a hole straight through it. Now, why is that useful? Because there's your endoscope. There's your orogastric tube. It goes straight through. Now, in relation to a tulip, that's what happens. This facilitates the introduction of very broad scopes. It's going straight through the tulip breathing tube and it's coming out the end. So this tulip can be in a patient's mouth, ventilating, directly connected to the anesthetic circuit, 100% oxygen. All you have to do to make them breathe is squeeze the bag, whilst the endoscopy carries on. So the endoscopy is in active process while the patient is still breathing. There's no insecurity, there's no intermittent nature of ventilation. It's continuous like any other airway at any other time. So, how does that help? Well, the tulip upper GI endoscopy method, you've got a secure airway throughout. It's in, you don't touch it until the patient pulls it out at the end. It's directly connected to a ventilator if you want. Now, sure, most of them will be spontaneously breathing. You've got 100% O2. You're hands-free, so you're not in and out the airway. It's not unstable. You're not messing around. You can squeeze the bag and get ventilation, positive pressure, any time. There's no apnea. The patient will then self-extubate and be fully awake when they recover with the Tulip GI endoscopy method. Now, let's talk about bronchoscopy, all right? Because, as I said, the oropharynx is a common denominator. A bronchoscope goes through it, and again, the current method is to basically anesthetize with propofol, midazolam, some sedation, whatever you like. But what's the ventilation possibilities? Well, a lot of people use high frequency jets. Some just use assisted ventilation in and out. Apneic oxygenation, well, I don't know, I'm not very keen on that. But anyway, that's for rigid bronchoscopes that look like swords, so that's a bit antiquated now. Controlled ventilation, again, that's rigid bronchoscopy stuff, and manual jet ventilation, again, usually with rigid bronchoscopes. Now, the current method, you can use different kinds of scopes, right? You can use the rigid type, you can use the endobronchial ultrasound type, and there's this new ENB stuff. But most bronchoscopes are just small, flexible tubes, aren't they? Effectively, well, they're not tubes, but you know what I mean. They're just small and flexible. Okay, now again, the problem with that is all of the same problems that you got with the upper GI endoscopy. So it's insecure, you're not in control. Poor outcomes, intermittent ventilation, hypoxia, hypercarbia, irritability, not great. Okay, so let's look at a bronchoscopy. We'll go into intubation, but this is basically how a bronchoscope would enter the trachea from a Tulip tube, right? So let's discuss the Tulip bronchoscopy method. Another one of those connectors. This one has a slightly tighter seal, specifically not to enable leakage, all right? So as you can see, there's a hole that seals around the end of the scope, and you don't get any anesthetic vapor or gas leak, so the IPPV pressures don't fall. Now again, the tube or the scope goes straight through it. Now this I should have mentioned earlier on, of course, but this could also be an orogastric tube, couldn't it? Right? So basically, an orogastric tube going through a tulip addresses all these issues of reflux and regurgitation. Okay, so again, the different connector, the tube, the scope, whatever you want, the orogastric tube, the upper GI scope, the bronchoscope, all go through here. Now, here is a bronchoscopy, and what we've got going here is the view that, I mean, quite honestly, I think it's optimal. That's as good as it will get, isn't it? Beautiful. Now I've seen that video about 100 times. I still can't believe how good it is. Anyway, so that's how easy bronchoscopy is with a tulip. Now again, you're going to get all the benefits that I listed earlier. Now, here we have all the advantages of the Tulip bronchoscopy method. It's a secure airway, you're directly connected, spontaneous ventilation or IPPV, 100% oxygen, hands-free, self-extubation and awake recovery. Again, now let's talk about endotracheal intubation. Okay, once again, through the tube of the tulip for the same reasons as bronchoscopy. Here we go. Now this is intubation through a tulip. The tulip is designed for nasal ventilation, but also for inline endotracheal intubation. If you introduce the tulip in the normal manner, if you inflate it,
in its normal manner, you will have a controlled ventilating airway. So if you imagine that the paramedic does this first, and then the consultant anaesthetist arrives with a size 6 or 7 endotracheal cuff tube that is itself lubricated, you can intubate through the tulip in such a manner. If I now inflate the endotracheal cuff, you will see that even blind intubation is possible. In a situation whereby a patient has a difficult airway, or in some form dangerous outcome potentially, we recommend that you intubate through the tulip using a bronchoscope through the endotracheal tube, because that way you will not fail. You do not need a laryngoscope. On extubation, you're also then free to remove the endotracheal tube at the end of the operation and then facilitate a self-extubation with the tulip when the patient themselves is awake. When the patient extubates, the patient is fully conscious. Laryngeal reflexes will have returned.
So that was easy enough, and strangely how easy it is in my mannequin. Didn't have to be. Okay, so now let's talk about ENT dental nasal surgery. Okay, the advantages: you're not intubating. Okay, so current method involves starting with a Gadella mask, then you're intubating. You need a laryngoscope. You need some McGill's forceps if you're using a throat pack. You also need succinylmethonium so you can intubate. You need a syringe and a needle. So in other words, a patient being intubated for an an ENT surgery is in danger from the paralysis. They're in danger from the endotracheal intubation itself, and they're in danger on recovery because they have a contaminated airway. Now, here's the thing. If Tulip is oropharyngeal and has an airtight seal, it is also blood tight, and it's here, above the level of the cords. So why do you need to intubate? The answer is you don't. You can just use an airtight seal and occlude the oropharynx and proceed with surgery. Now, in terms of what they are, here's a normal tulip, right? These are just tulips with additional length tubes. Okay, so the connectors are basically based away from the site of surgery. Like here is a reinforced version, all right? So basically what happens is it sits here and then it comes out of the mouth and it comes down to here. So hang on, my hand's in the way, but you get it. But basically it comes down to here and the connector is out of the surgical field. If you're basically doing tonsillectomy, a Boyles-Davis gag will fit on this. So you get two types. You've got the reinforced and you've got the preformed PVC type. But the point is you can perform ENT dental nasal surgery without the risks of endotracheal intubation. Here we go. We're going to watch this. We're going to watch this video now. This is ENT tulips in use.
The tulip has a principle of an oropharyngeal cuff between the soft palate uvula and the tip of the epiglottis at the front here. That then circumferentially seals the oropharynx, giving an airtight, blood-tight seal, which then means you can use the tulip for oral ENT dental type surgery, septoplasty for example. For a number of conditions you can use this version. However, this is a specific ENT type tulip. In this particular case, there's a preformed plastic PVC tube. Here we have another version. This is a flexible with a metal spring within. Both are designed specific for ENT. In this particular case, you insert the tulip in a normal fashion. The tube is designed to be pointing south so that it can be secured away from the operation if you are, for example, doing a septoplasty or something on the nose. In the same situation, everything is the same except the breathing tube in itself. Once the tulip is inflated, you can ventilate in a normal manner. The same situation is applicable for the reinforced type.
So you can see that it works in exactly the same way as a normal tulip. Now, again, so what are the advantages this time? Well, if you're not going to intubate, there's no paralysis. There is no intubation. You can't leave a throat pack in. You're not using a Goodell, a mask, then an ET tube, and then back again. You can allow the patient to self-extubate. And remember, when you've got a contaminated airway post-tonsillectomy, that's really quite useful if they're awake when they recover. Now, the next thing is there's also a significant saving in cost. No harm done, is there? Additional safety, lower cost, okay. Well, anyway, that's dealt with in video 7, which talks specifically about the costs and the benefits, because you're not using like 4 sets of equipment. So we'll go through that, and no harm done if we're reducing waste as well, is there? So here's the Tulip website. I will see you on another video. Now I'm going to make one that I hadn't planned to make, but basically I've had a request to go through the sizing, the cuff volumes, and all of that. So I'm going to make a nice little short one that describes sizing, volumes, what you should do, what you shouldn't do. And in fact, I think I'm probably going to focus on what you shouldn't do. See you soon.